Okay, let's take a look at rheumatoid arthritis. We're going to first look at the case presentation, and we're going to look at the introduction, and then in other videos we will look at different sections. So first, the case presentation. A 40-year-old female sought medical attention because of a 7-week history of pain and swelling in both wrists and knees. She became fatigued and lethargic several weeks prior to the onset of joint pain. On examination, the MCP joints and wrists were warm and tender. There was no alopecia, photosensitivity, rash, or kidney disease. In a follow-up visit, the patient continued to experience joint stiffness for an additional 2 months. In addition to swelling of the wrists and MCP joints, tenderness and joint effusions existed in both knees. RF was positive and subcutaneous nodules were noted on the extensor surface of the forearm. So in this video we're going to also cover the introduction. Rheumatoid arthritis is a chronic systemic inflammatory disease, the inciting trigger of which is yet unknown. RA primarily, but not exclusively, targets the synovium of the joints. It is common for patients with RA to manifest fatigue, low-grade fevers, anemia, and elevations of acute phase reactants, such as the erythrocyte sedimentation rate and C-reactive protein. It is widely believed that this disease is a prime example of an autoimmune disorder in which the immune system primarily attacks the synovium. Proliferation of synovial tissues results in swelling and erosion of surrounding bone and damage to tendons and ligaments. Exciting advances in the treatment of RA have centered around agents which modify or forestall the progress of the disease, and more recently, biologic agents which interfere with the action of various cytokines, especially TNF-A and interleukin-1, which have been incriminated in the pathogenesis of RA.